Okay, everybody's almost getting settled in here. And first off, I want to say thank you for the opportunity to come here and share some wisdom with all of you. I applaud each and every one of you to get here. Chicago in February is not the nicest thing to do, but I can tell you, it's been 5 years since I've been here last to talk about digital workflows. And so much has changed in those first 5 years. But I will tell you how I got started in dental technology. I think it's really important to really reflect on where we start in this life and how we develop our integrity as it comes to everything in life. So I started in a dental laboratory in 1985. I walked into this lab, I left home at 17, and I needed to find a job. There was two things in this life that I like to do. I like to surf, and I like to fish. So I moved down to the beach with no money in my pocket and decided that I needed to find a job. So I walked into a dental laboratory, and they were hiring for a driver position. So I was always one of those guys that liked to work with my hands and learn a trade. And this gentleman that owned this lab was nice enough to give me the opportunity to start on that plaster bench like everybody does, move into preliminaries. Then I went to setup, processing, and finish. So I was a complete denture technician inside of 5 years, which is unheard of today. I was really bad at it, but it was something that I was confident enough, and I had nothing to lose at that age to move back inland and hit the bricks. Go to the doctor's offices and just try to solicit them to learn more about this and try to make a little bit of money in this trade. That lasted about 9 years. I worked almost 7 hours or 7 days a week, 13 hours a day, and I found a way to better myself as a technician. It's like anything else in this life, it's based on repetition. The more that you work with something, the more you have the opportunity to improve. It is always based upon your ability to want to improve and not just get that case out the door. It's so often that I see in this trade today, one, we're not bringing in any new technicians. It's really tough for that. But two, that ownership of our cases has really gone away. The goal is to get that case out the door, get into the office, and hope you never see it again. And that has not ever been my mentality. I don't look at that aspect. So as stated, today I've run a successful laboratory for going on 35 years now, and I have seen the ups and downs of digital technology, but we specialize in implant restorations using full digital workflows. And what I'm going to show you today is not the only way to get to the final restoration, but I'm going to share that we've done in the last few years with this technique at least 400 arches with really good success in my little laboratory. So I like to say everything starts with a team. And my team approach to dentistry is based on ownership, as I mentioned. It's really super important to have relationships in this business. The next couple of slides, I'm going to talk to you about relationships. Relationships to me are why I get up in the morning to do what I do, because I have a duty to make these restorations as good as I possibly can. This gentleman here, I'm going to give 2 shout outs. This is my number 1 client, and if any other clients are in this room that I've worked with, I'm sorry, but this guy is incredible. And the best surgeon I've ever worked with, but more importantly, he's the best man I've ever come across. He's humble. Second best. Min's the first best in this room. So
I'll take it.
So anyhow, I need to give a shout out to this. The cases that we're going to talk about today are his cases. He's an exceptional surgeon and a wonderful friend of mine, best friend in dentistry. I text him more than just about any. I think Min's a close second, but
He's awesome. He's amazing.
Second set of guys here, and this particular workflow that is going to be discussed today. I'm going to be very gentle in how I present this because, one, this is intellectual property. I recommend that if you're excited about what I show you today, that you look up this team here. The guys in the middle, Art and Fernando, were instrumental in coming up with a way to utilize an intraoral scanner on surgery day to collect coordinates with perfect passivity without using photogrammetry. So how many of you guys in here have used PIC, iMetric, maybe Micron Mapper? Okay, so you guys all have some background with the path. All we're trying to do is start with a set of preoperative models and maintain the coordinate system along the way. Let's go ahead and talk. So the power of facial scanning, I think, is unbelievable. This slide here I found on the internet, and I just thought it was cool, so I threw it in there. But why do I love it? I can tell you why. So without reading this stuff, I can just tell you for the truth. The reason why I love this, it gives me the opportunity to not rely on just photo documentation. It gives me the ability to see the preoperative situation in detail. How often on these cases we have, perio-involved teeth to the point where they're flapping around and the lip itself is going to collapse back in on that area. We have perhaps collapsed verticals that we can see in profile scans, and often it's skewed in a 2D photo. So a facial scan is going to allow you to see exactly what's going on, and it gives you an additional tool to be able to make your designs match that information. Secondly, I better do the cheat sheet here. So lip support, as I mentioned. So if you're going to compare, this is a really important item on this stuff, guys. So often when we're doing these designs, they're in a really poor shape. These patients have suffered for a long time. They're ready for an amazing transformation. But you don't want to lose their identity. And so often when we're looking at preoperative data, it's very easy to just say, okay, we're just going to cut all these teeth out, we're going to slap a denture in there and send them on their way. What this class is about today is how we can take a pre-surgical condition designed effectively for a prototype. So again, that input data, acquiring quality data is only the first part of the equation, guys. Understanding how to utilize it and substantiate it is the super hard part on this stuff. Just because you get something in your inbox and you look at it and you just think, well, okay, this is probably right. There's so much more to it. The preoperative condition will teach you everything if you know what to look for. So we're going to talk about what the biggest challenges on these types of restorations and what we're trying to accomplish. As mentioned, those preoperative records are super important, and I'm going to go through exactly what we request and how we utilize it. This part right here, the one coordinate challenge. If you understand the real path and what we're trying to accomplish here, we're bringing in scans, we're aligning the face to it, and now this coordinate is going to be transferred all the way along all subsequent scans that we're going to utilize in this case fabrication. So as we move into the surgical aspect, we have to have a way to align back each subsequent scan to those ideal coordinates in that one coordinate system. So this is a little teaser. I'm working on something that is going to be pretty cool. I don't know why I'm showing this, but I just think that in the real reason of why I'm here to give back to this trade, I'm going to design up a very specific library that's going to allow you to bring in full contour wax ups as a Ponic and essentially adapt it to the facial scans in 3 clicks. Scaled, fully ready to go, in full perfect occlusion based upon the information on your alignments. Now that part to me is a super cool, super fast way to go about the service on these types of same-day services. And utilizing the same denture principles that I started with in this trade, it was based upon me being able to visualize where a tooth goes in a negative space. So often if you've worked with good quality clients, they'll fox plane that wax rim, they'll take a face bow, you get it on the articulator, and you're starting way faster than most places. But how many have you guys got that nasty mush bite? You're looking at the actual upper and lower, and you have to make a correlation between landmarks to make the right choice to start with where you're going to place that tooth. So having the face has allowed us to take this type of information, and very much like the old Dentsply tooth libraries where you would have tapering, square tapering ovoid, ovoid. It's all based upon the face. The face is the number one thing that is going to aid you in making better designs. And that's what this library is going to be. It's not ready yet. It's a little too complicated for most people, but I can tell you that when I release this, it's going to revolutionize how these pre-surgical wax-ups are done. All right. So we're going to look at a case from start to finish, and as mentioned, it's going to utilize the InstaRISA workflow. I'm not going to show all the secret sauce on this, and I really recommend that you go and look at their website and learn more about facial scanning. So this beautiful lady walks into the door. We have a lot of challenges to overcome. We have all this terminal dentition that needs to come out. We have a transition line that is going to be quite complicated, and the plasty is going to be very big on that upper arch. So everything starts with a video, and that video is coming from the client. The client is working up the actual surgical aspect of this. We collaborate, we talk about dimensions, we look at the pre-existing condition, and we adapt and make decisions based upon that information. So very simply, he'll have a guide software up. All of these cases that this gentleman does are freehand. And you're going to be just astounded when you look at the precision that this gentleman can do. He's unusual in that regard. But what it allows us to do is when we have that video of that pre-surgical workup where I can see his proposed fixture placement in relation to the adjacent dentition, the root forms in a CBCT format, it gives me the guide to be able to know where the plasty is going to be so that I can transition to the intaglio in a manner that it will blow your mind. Essentially, very close off of our pre-surgical wax-up. As we move into connecting the dots and wax-up bridge, there's very little adaptation to the intaglios based on this planning. So we're going to go through some of these pictures and what we're looking for. I like data. More data, the better. Better photos, the better. I'm looking at a lot of things here when we look at these preoperative models. I'm looking, one, which teeth are solid? Which ones do we have mobility to? Because we're going to have to align back to these coordinates. How do we know that? Well, again, communication with your client is going to give you that information. So you can see here on the lower, that defect in the anterior segment where it's resorbed so heavily. That's essentially going to be the floor of the mouth for us to design this case up. So the plasty on these remaining teeth are going to level that aspect out. So you can see rather clearly her profile picture is pretty darn good. She's not overclosed. It's ready to go. But look at that lip support. Look at that incisal placement based upon where those posteriors are hanging. She's a beautiful lady, but her teeth is just a flippin' train wreck, and we're going to have to fix this. So this shows you the power of facial scanning. Yes, it's ugly. Yes, it's kind of scary. But what this does is it substantiates the bite relation based upon the IO scans that we've had come in. We'll have two ways to correlate the bite. We have the first one from the intraoral scans that are related as they come in. And then we have the facial scan that allows us to align each individual scan to the face to substantiate that the trios bite or whatever IO scan is correct. So again, when we talk about profiles will teach you so much. My goal is I got to figure out where to put that incisal edge position based upon where we're going to cut the bone, and 2, where the transition line is going to be. Those are my two things that I need to know. So again, I'll bring in this library. This library is something that is super powerful. And if you look at this big mouth, look at that buccal corridor. Look how much she is showing. You know, she goes back to almost the second molar, I think, on this case. And granted, the facial scan's cropped in a way that might be revealing a little bit more. But this is essentially my plan for us to move forward once I get the surgical coordinates to connect the dots to the wax up. So it's 2 orders, guys. The first one, I design in Denture Designer, or I bring in my library. And once I have this information, I'm waiting for the 3 surgical scans that's going to be required for me to connect the dots and make a tie-based style restoration. So again, we're looking at all of the things that we normally can't see without having a facial scan. How many of you guys have ever mounted a case on an articulator based upon how the model was ground? And you're looking at that top line and you're thinking, okay, yeah, I'll set these teeth to match that top line, and you correlate with a photo and you see a try-in photo and the thing is running down a mile downhill. It's just very common. So having an extra piece of data allows me to substantiate that my plane of occlusion is going to be very close. And that is invaluable. I can't do this. You got to realize these things, there's no try-in. We're going straight to a prototype on here that they're going to wear for 5 months. My goal is 2 things on this. 1, passivity, number 1 thing. It's what's going to kill this case if I can't make it passive. And 2, a manageable bite outcome. What does that mean? You know, the guys that say they do these types of cases, they go straight to the mouth and click, 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 and perfect, and there's no bite adjustment, midlines are bang on perfect. I'm here to tell you that that might happen sometimes. It's definitely not the norm, but we are so close to be able to dial this stuff in, and every year that we proceed, we're getting better. Because we're learning. We're evaluating the data on the cases that are less than perfect. So again, big Cheshire cat smile. So here's the start of the magic. If you understand the 1 coordinate system that I was outlining, we have to have a common fiducial that's going to align back to our pre-surgical. So if you look at that carrier right there, that's a 1-piece implant with the actual carrier to torque that fixture to place. And we're going to utilize that geometry as we move forward on the case. We'll get a scan of this condition here, and we'll align that fiducial back to our preoperative model. So then we can take the rest of the teeth out. We have something to align these implant coordinates back to, right? Well, how do we get the next step of the equation to actually fit? So you can see this surgery. It's an amazing surgery when you look at the right part of the equation here. You know, the biggest problem with all on X is not managing the bone properly for hygienic contours. You can see very clearly in this photo, everything is flattened. He'll graft back in the sockets. And now we're ready to pick up our implant coordinates with an IO scan. So you might see this mass of blue and think, what the heck is going on? What's the reason behind this? That's twofold, guys. First is to control the bleeding. We're controlling the field. Anybody that's scanned in a moist environment knows that as you're making your scan path coming around the arch form, the scanner is going to struggle because the first picture that they're trying to align to the second picture has changed because now there's moisture there, blood or something that has changed, and the software gets confused, and that's where cross-arch distortion comes in. So the blue impression material is very rigid, has a lot of topography there. It aids the scanner in tracking along the arch form to get our implant coordinates along with our fiducial again. So we're going to take that fiducial, align it to the pre-op. We're going to take the second implant coordinate scan with the fiducial and align to that. And now we have our implant coordinates aligned to our actual wax up. It's ready to roll. I mean, literally, if you understand the wax up bridge workflow, you bring this in, run it through Scan It Dental, and essentially rename your wax up as wax up bridge, and you're ready to go. So the final scan is going to be our intaglio scan. That intaglio scan is going to be essentially a putty index of that because, again, scanning a wet field is going to be rather difficult to get accuracy. This is the least accurate scan that we're going to work with, but it gets us in the ballpark, and we do it in a semi-analog way. We take a big wad of putty, put it into a tray, seat it down, and what that aids us in is, one, it's going to compress the tissue in the areas around the multi-units that are the most pliable. So we need to have a way to when we modify our intaglio over a wax up, that is going to push in the right areas. Now we can get away with a little less pressure in the mandible. We can get a little high water on these things. But it's ideal if we can start our compression now so that those tissue can scar over in the most advantageous way. So when we go to the definitive restoration, we have a really big leg up to make that prosthetic hygienic. So the upper is very much the similar path. The difference is you can't see the fiducial that we have in the middle of the palate here. We didn't get that picture for some reason, but very difficult case. Look at the dimension that we have on this. It's going back to the pterygoids. I don't believe this is a zygo case, but I think we got 6 fixtures in this going all the way back to the pterygoid, to the point that we're going to have a dimension issue as we move forward as we look at this. And I'm going to show you how I overcome that aspect. So again, now you can see that fiducial in the middle of the palate. Essentially, that scan was going to be the first scan that was aligned to the pre-op. And the second scan is going to be our implant coordinate scan. So you see very clearly we're doing the same thing. We're managing that by isolating the field, keeping the blood down, adding the topography. And what I'm here to tell you is you can get absolute passivity when you follow a very specific protocol to scan these cases. It's not easy, guys. I'm not saying that the assistant is going to go in there and scan in about 15 seconds. It's not going to happen. You have to be very, very, very careful to get the right data on this, and scan path is absolutely critical on this aspect. And again, this is another really good subject to address once you take that case.
Is this done before suturing or after suturing?
This is surgery.
No, suturing under the gauze.
It's after, so you're going to see here in a sec. So right now, this stuff, there's no sutures there because obviously to try to get this off, it was going to lock her in the suture. So it's an open field at this point. So now it's sutured up. And again, we got to take that third scan that's essentially going to be that putty impression that we're going to line back. Well, you don't see a fiducial in here. How do we align that back to our pre-surge? Well, I have a library that matches the healing abutments to our scan abutments. Quick, easy, fast, efficient. It allows me to have all the data that I need after surgery and in a very systematic way. I can tell you a quick story. First double arch that Min was involved in. I told him the scan for this is going to come in this time, scan's going to come in this time, and this time. And I was within
1:30, 3 o'clock,
yep.
4:15.
So it was almost to the dot on when the scans come in, just because I've worked and done so many cases with them, and I know the complexity that goes past a certain time when the scan is supposed to come in. I know that he has a bleed or there's some sort of other complication. So this system, what we're utilizing is we're doing next day prototypes milled in PMMA. So we're trying our darndest to try to get that, what I call the sacrificial appliance. It's the appliance that we're going to learn everything from, and no matter how perfect I do my workup here, there's going to be an option for me to improve it as we move forward with the digital finalizing of the data. So let's look at the prototypes. It's milled. It's replicating that pattern. My goal, again, those intaglios are absolutely the most important part of the equation. I don't care what the teeth look like. I want to make sure this lasts. And I'll be the first to say, in my business and what I do here, guys, my goal is to make the thing last. Making it pretty is second. And I'm going to always tell you that if you're going to own these cases, they absolutely have to be managed for the length of the duration of what you think this thing's going to last. They didn't get to this position by having great hygiene, guys. The teeth are rotting out for a reason, so I got to give them a leg up to be able to clean this. So again, very long reach to the PMMA to the pterygoids there. Just a very, very large, wide arch. And while I was able to manipulate the cam and get it into a PMMA disc, you're going to see what's going to happen as we move forward. Show you a couple more photos of this.
Shameless plug tomorrow if you want to know how to cam things effectively.
There you go.
We're talking about that.
So the one thing that I want to point out, I didn't make a slide of this, and I should have, is since I utilize a reductive technology, and this is completely modelless workflow for this, we have no verification whatsoever. My PMMA prototype is my verification. So I have to be rather certain that I'm prepared for the potential that maybe this thing doesn't fit. That doesn't happen, guys. And all the arches that we've done, they always fit. What they don't do is nail the bite every single time. And there's so many factors that can go into why that doesn't align up, but it's a billion times better than doing a transition denture. I'm telling you for a fact, after a long surgery, that doctor is not going to want to take a denture, cut it out. They're never going to get these types of intaglios. It takes forever to get that. It's very, very difficult. So why add extra stress, especially if we have the tools to be able to manipulate the data post-delivery of our prototypes and post-adjustment of the prototype to make wise choices and improvements. So this is amazing. One day, look what that tissue looks like. That's just crazy to me. You can still see the sutures, obviously, and one of the healing abutments off in this photo, but it's a little more gnarly, but still, one day. And what do we see? Well, the plane of occlusion looks a little funky. I'm showing a little bit more teeth, and my midline is ever so slightly off. And whenever I use that term ever so slightly, it's a fucking lot off. So, what does that tell you, guys? It tells you that there's not a system on this digital planet that is foolproof. As much time, effort, and passion as I put into this, there's small amounts of inaccuracy based on that fiducial marker. You got to realize that he's taking that carrier off and putting it back on. It can be a tiny bit of rotation here. And if that fiducial moves a quarter of a degree, you got to imagine by the time it gets around this end of the arch, it's so much more on this part. So that's why you see the lower cocked. It's just a little rotated, and when you rotate on that plane, midline's going to shift, right? But it's manageable. Doctor did a little bit of equilibration, and she's going home with teeth. Is it perfect? Not even close. Is it pretty damn good for a prototype for a next day surgery? Absolutely. We have some unique shapes in this library. She wanted not to be completely square and perfect. She wanted to have some unique contour to this, and this is the mold that we chose. So again, you can see rather clearly where the doctors had to adjust. And this is our outcome. Next day after surgery, we have something that she can function with and be quite happy with. And as we move forward with this case to go to the definitive restoration, after 5 months, she's going to come back and we're going to essentially take some new records. And it's going to be dependent upon what we're trying to improve in the final restoration. Well, we know we have to improve the lower midline. We know we have to find a way to maybe tweak the anterior long axis. But very close. We don't have to do too much. And now what I'm going to share with you is going to blow your mind, and it's going to be hard to follow, and I'm going to say it one time, and I expect all of you to go, but if you catch it and you really understand what I'm going to say, it's going to revolutionize what you think about how bites are related to one another. So if I have a wax up and I have perfect interdigitation of this mold, it's perfect, it's beautiful. I know that this static arch, the upper arch, is not moving. It's ankylosed into the bone now. It's perfect. But the lower, instead of having that perfect relation, is slightly off here. Well, was my pre-surgical records off? Or was my implant coordinate records off? And when I say off, I mean not aligned to the pre-op. So essentially, all I'm trying to do is maintain this coordinate, all 5 or 6 implants here, in relation to these 5 or 6 implants, and maintain that information as we move forward. When we have a very specific shift like this, I'm going to manage the lower. And how I'm going to do that is on those second set of implant records that are going to come in, he's going to scan each individual arch to show me the adjustments that he's made, close down the vertical based on that information, and I'm going to take the original wax-up bridge and implant coordinates and combine that into one file. So it'll essentially be that wax-up with scan bodies coming out of it. I will then take that combined output of the upper and lower adjusted prototypes and align that back to my first upper scan. We know that's static, it's not moving. There's no way that can change. So if I do that, I'm going to be very clear to know that where my implants have moved. It's still the same spatial to connect to the fixture, but in relation to the upper, it's moved. So it's very fast to be able to take your pre-surgical, change it, add the implant coordinates in the new spatial position as it relates to the upper arch, and connect the dots again. And you're going to see very clearly that's what we've done. So again, she comes back to the office, and doctor scans the tissue. We take a look at where things are at. You can see this case healed up rather well. Just beautiful results here. Look at that symmetry from fixture to fixture. Multi-unit abutments are at the right position, guys. How many do you get them either super deep or super tall? They're very rarely like this, and this is by design. This guy has probably 150 multi-unit abutments in his office at any time. He has every cuff height known to man, and that's the difference on these types of cases. It's absolutely a pain in the ass if you transition a case with a multi-unit abutment that's too tall, because now everything that you've done up to that point, if you choose to replace that multi-unit abutment with the right cuff height, has to be redone. There's no way to do that. So that's why these doctors are very reluctant to do that. So having a client that understands the power of hygiene based on multi-unit abutment height is absolutely critical for the best results that you can have. So look how beautiful that tissue is. And this is the adjusted prototype that she's worn for 5 months. We still see our problem. We need to take this information, and as discussed, I'm going to take those individual scans and combine them together in one STL. So I can easily align it back to my original wax-up bridge to allow me to align the combined output on the lower to move the implant coordinates. Clear as mud, right? I know it's overwhelming, and I take this to hopefully inspire you to think differently about how to manipulate a bite registration when it's an upper and lower arch, especially when the upper arch is very close to being in the right position. It's super fast to change without having to redesign if you understand the concept. So you can see, even with all of this information that we have here, she can't keep it clean. And it's not because that PMMA is not super dense and not polished to the best degree. Yes, we have some composite on that. Yes, we have some colorants on that. And yes, it might attract a little plaque like this. But ultimately, what we see in this is maybe our gingival carvings is a little bit too pronounced. And we need to rethink that aspect for this particular patient as we move forward. Again, you can see very similar. But look at her. Even with this malocclusion, it looks pretty darn good. She's pretty thrilled with this. She thinks that she's got a new lease on life, and she's, to me, looks 10 years younger, maybe 20. So we're going to segment out here and talk a little bit about what I had to do on this flipping case. So you can see rather clearly that there is a double structure on this now. After we realigned everything and came back to our CAD design, and we brought it into the cam and volumetrically increased it to see where it was going to fit in a disc, it's absolutely impossible to fit it in the disc. With this length and this type, there was no way to get the offset to be able to mill this thing effectively. So ultimately, I had to reverse out a bar from the intaglio. I recommend, guys, that when you do these bigger cases like this, something you talk to your doctors about, because this adds a tremendous amount of cost to it. But what it doesn't do is it doesn't negate all the work that you've already done. I'm utilizing B4D in this to take the coordinates from our original wax up that's already been converted over to a prototype with tie bases, and now we're going to go ahead and make it direct to fixture. On this bar, I think we actually used tie bases on the bar because we used angled screw channels to idealize a couple things, and I'll talk more about that in a minute. So rather easily, you can see, this is how we're going to overcome dimension. We're going to mill that bottom part in titanium, and I'm thrilled that I was able to sneak a design in like this. I send it to my client, and he freaks out. He says, "What are you doing? I already got this thing cammed and in the mill." And he goes, "There is no way this lady with this widest buckle corridor is ever going to accept a metal tooth in the last unit." So I said, "Well, what if we change the projection and just make a smooth transition and not have that aspect?" And he says he was fine with that. If I was to do it over today, I would go ahead and do thimbles on those last two units and make a couple ceramic crowns over the top of it, cement it to the bar, and we'd have a full complement of teeth in ceramic. But to be quite frank, she's functioning beautifully with what we've done here. So let's take a look at how this actually works. Well, if you understand that program to segment out, there is nothing more frustrating than to take a beautiful design and realize because of this situation, you have to destroy it, redesign it, and find out that somehow you made a mistake and changed some little thing and she hates it on delivery day. Because this is going straight to finish at this point, guys. We're not going to go do another try-in at all. Everything's based on the understanding that, one, our prototype's passive. Two, we have all the data to be able to correct the malocclusion. And three, the minor bit of aesthetic changes are going to be rather easy to have a successful outcome. The window of opportunity is huge. And this is the restoration. I can mill the zirconia, I can do the sleeve, and solid zirconia. So you can see I've polished off those molars. Anybody that's worked with zirconia, if you guys are master ceramists, more power to you. My goal, as I mentioned, is function. I want this thing to last as long as I possibly can. I don't want to put glass on it. I want to use liquid ceramics as much as possible. And I want to be able to give something that mimics the prototype that I've done in color and contour. Done. That's all I have to do. Seems easy, right? Very smooth contours. And again, those challenges that we had are all taken care of. So look at that intaglio. That's something that you guys should shoot for. That is the pinnacle of perfection when it comes to, one, AP, and two, the highly polished intaglio. We do something a little bit different than really what the lit says. The color aspect of coming over the inside aspect of it is something that we've continue to do, even though the lid is showing that polished zirconia is better than even the highly polished liquid colorant that you put on there. The tissue is going to be attracted to that a little bit better. So in a perfect world where your client, your patient is not going to complain that she sees a little bit of white, that's the best path. But this is a very close second. It's going to resist plaque accumulation because we've done a very specific type of polishing post-glaze. We're more or less knocking the glaze all the way off of it. All the glaze is doing is sealing any type of microporosity to it. And it's like a mirror at this particular point, and that's what the tissue is going to react the best to. And this is our final outcome. We fixed all of those little challenges to get to this position. And with this, every single case that I see, I can tell you right now for true, if you're like me, there's not a case that goes out of my lab that I'm perfectly happy with. I get very close to feeling somewhat satisfied. I know that I've changed a life and I've been a true partner to my client. And that is what gets me up in the morning and gets me to say, hey, I get to go to work today rather than I have to go to work today. Those relationships to me is why at nearly 60 years old, I'm still pushing forward, pushing hard, and loving every minute of the day as I do digital dentistry. And she's thrilled. I just pray she cleans this son of a bitch. All right, guys, let's talk about additive and reductive. I don't know why I don't really stress this a little bit more. I know that given this workflow and what I've shared with you, you know that I'm a reductive guy. Inherently, it's exceedingly wasteful and time-consuming. And as the material science has changed for our additive materials, it's coming up to the point where we can almost rely upon the strength on these longer-term provisionals. You've got to realize we're not doing it in 2 weeks to put them into a final. We're literally waiting 5 to 6 months on these things, so we want to make sure it lasts. We want to make sure that the material is dense enough that it's not going to drop the vertical dimension in that time frame. But most importantly, I got to be able to feel 100% certain that if I'm going to do anything additive in this workflow, that I have a way to substantiate that. How do you do that with post-processing resin? One part I didn't mention to you is what I do in these situations. Since these are next day prototypes, after we mill that PMMA, we assemble it, we put the tie bases on there, and then we screw analogs on the bottom of that prosthetic and pour a base model. Why do I need that model? Well, I'm going to move forward to a volumetric changing material that I need to have some sort of validation for. So many of these guys today are milling direct to the multi-unit and using some fancy flip and screw. I can tell you right now, it's absolutely impossible to get pure passivity every single time using that system. It just doesn't work, guys. Conversely, when we look at milling a 1-to-1 ratio, if your CAD coordinates are correct, if your CAD design is correct, 100% that passivity is going to be realized. And if it's not, when the prototype goes to the mouth, we're going to deal with it. We're going to take a secondary scan and we're going to knock out another prototype based on that information. That's a super, super, super rare occasion when it comes to this aspect. So let's talk about some solutions on other aspects and some things that I think are super important to talk about. So, as mentioned, I utilize the B4D software, and that has allowed me to fix up a lot of really poorly placed implants and make these prosthetics that much more hygienic and comfortable to the patient. When I take a look at this, we have some poorly placed zygos. This isn't a Ramsey mean case, but it was a case that came in my lab and we restored it. And we did it with tie bases, and I sent it off, and the patient loved it. It was beautiful. Our only complaint was, what the heck is this speed bump in my palate? I hate it. I can't stand it. It's driving me nuts. My tongue's going to it. It's raw. Well, it's just dimension, guys. You have to recognize if I got even a short tie base in there, I need to have enough volume of material to go around that tie base to have the strength. So what if we thought a little bit different? And again, being able to take the exact same pattern, just change the actual interface, and then mill the bar in a manner that I can totally exploit the strength of titanium. And that's what we've done here. It's almost perfect, even with those shitty placed implants. All right, so here's another little pearl that I want to share with you about multi-unit abutments and something that you should talk with your clients about. So on traditional all-in-4 cases here where the terminal abutment is distalized, and when you're looking at this particular thing, looks like we have pretty decent AP. But very often in these atrophic arches, even in an all-in-4 situation, we're going to have the anterior fixtures too far lingual to the actual pattern. And when you look at this particular case, we know that those two terminals have been uprighted probably 30 degrees to move forward to that position. And if we were to think about how we can improve that anterior segment, because you got to realize, think about how much is that's going to be extended back to the palate. Well, how do we get around that? Maybe we think outside the box, and instead of just using a straight multi-unit abutment, maybe we'll use a 17-degree angle corrected and angle correct it forward. What that's going to do is going to allow us to have our projections. I don't even know if this son of a bitch works. No. Where is it? All right, Min, CTO, it doesn't work. This part would come farther forward. The most lingual aspect of the abutment, the projection would be higher and coming this way. And we'd be able to make that lingual contour of the posterior part of that flange that much more thin. So it doesn't get used very often, but it's a very versatile way to fix these types of situations. Again, it's based upon what that client has in their office for inventory. The more that they do, the bigger their inventory is going to be. And if you recommend to talk about it, take a picture of this, send it to your doctor, explain some concepts. These little things make the difference from a great case to a super spectacular case. All right, guys. So this slide I've used before because it's super important and probably one of the most misunderstood aspect of full arch dentistry. We've been afforded a really powerful tool utilizing angle screw channels and ball head drivers. And what it was initially designed for was to hide access holes. You know, take that poor fixture inclination, crank back that channel, get it behind the incisal edge, and Bob's your uncle, you have something that's not going to show a facial screw hole. Well, yeah, we're going to do that. But if you look at this case, not every single one is in the poor position. But it's in a poor position prosthetically for the strength and milling of this restoration. So very common, I will use angled screw channel to put the hole in the most advantageous path so that I can mill this in an easier fashion. So if you think for your CAD and be critical on the challenges that you're going to face trying to mill a prosthetic like this, you have amazing dimensions on these things. You have long reach with very fine tools that you have to be able to think that if your machine has 35 degrees of correction on it, you have to be within inside that. So by angle correcting and milling from the top for that aspect of the channel and using a tie base on the bottom, you can make the pattern stronger because you're going to place that screw hole in the right position or the most advantageous position. And that benefits the entire treatment plan. All right. So you've heard me talk about the intaglio ad nauseum. But I really believe that this is the most misunderstood part of the equation when it comes to these cases. So you're going to see here we got the same pattern, but it's been manipulated 3 different ways. And we look at from left to right, I call each one of these things a specific term. The left is slope, the middle is flat, and the right is point. And each one of these are a tool in your toolbox to idealize the intaglio contact points on maxillary arches. The most common is that middle flat. That's what we go with 90% of the time. But often, where we have a transition line that maybe wasn't managed perfectly, we're not going to ridge lap that. So often you see those nasty, dirty diapers of a restoration on Facebook or social, and it's because they're trying to overcome that, but they're not thinking about how the patient's going to clean it. So we'll do a slope. The contact point will be over the height of contour of the crest of the ridge. And with that, we're able to have contact, hide that transition line a little bit, but still have the lingual open and cleansable, and allows us to maintain that prosthetic. As mentioned, the second one, flat, is what most people use. The most rare and the most difficult to overcome is the point. And that's generally used on ridges that are very, very atrophic, thin tissue, and your contact point is going to be on the very crest of the ridge. It's difficult because you have such a small area of contact that it's very easy to have an open intaglio where air is going to escape. But with this, those flat aspect of the middle intaglio was going to be very difficult for the clinician to seat the restoration. We want a smaller contact point in those areas for that one reason, because we want to make sure that they can get it in. So when we do these types of restorations, very often I will design it more than what I think, and I'll talk to my client about it when we move forward with the case. So it's a very rare situation for the third one, but I think it's telling to have that in your toolbox. So you can see from this angle, very similar. You can see we've got a little bit of dimension there. So very, very similar when you look at it from this view, but it's completely different when you look at it from the intaglio. All right, guys, Maverick says I've done my duty. I can get the hell out of Dodge here for today. I want to say thank you for your time and attention. I have some time to be able to talk about questions if you have some. I would love to be able to open that can of worms up, because God knows there's going to be some crazy ones, but I'm here to give back. So please, if you have an interesting question.